Hello and welcome everyone to another virtual program by the Macular Degeneration Association. We're very happy to welcome you to today's program. And we also are very thankful for our sponsors, Regeneron, Apellis, Ocular Therapeutics, Merck, and Notel Vision. Without their support, we wouldn't be able to do programs like this. And speaking of programs like this, if you enjoy programs and you want to see some more, we do have more virtual programs scheduled for the remainder of the year, so please join us for those. And also, we're doing in-person programming. So if you want to visit our website of www.macularhope.org, you will find the full list of places that we will find us this year all over the United States. So if you can join us in person, we'd greatly appreciate that as well. Today is going to be a question and answer talk. So as you see your questions come up in your mind, please enter them into the Q&A tab at the bottom of your screen. If you do not see the Q&A tab, it may be under the More button, but that is how your questions will get answered. So at any point during the program, as our speaker is talking, if you think of a question, please go ahead and just put it in there. It'll be there till the end of the program, at which point the doctor will talk about the questions asked. So don't hesitate, get your questions in as soon as you think of them, and they will be answered in order. Also, we will not be taking any raised hands, and you will not be able to speak on today's webinar. So if you do have a question, again, please go through the Q&A section of the webinar and do not raise your hand. If you do find this information helpful and would like to support it, you can also do that on our website at macularhope.org and make a donation. We are a 501c3 nonprofit, and your donation is tax deductible. In the meantime, we'd now like to turn our attention to our talk. It's going to be about geographic atrophy and what is it. We are truly honored to welcome our distinguished speaker today, Dr. Jeremiah Brown Jr., a board-certified ophthalmologist with more than 2 decades of specialized experience as a vitreoretinal surgeon. Dr. Brown has dedicated his career to the diagnosis, treatment, and research of diseases of the retina and vitreous, a highly specialized field that sits at the forefront of ophthalmic medicine. Dr. Brown's expertise extends well beyond clinical practice. He has served as a voting member of the FDA's advisory panel on ophthalmic devices, contributing his knowledge to decisions that shape the eye care standards at the national level. And he has also served as the ophthalmology consultant to the U.S. Army Medical Material Development Agency, a testament to the exceptional confidence his peers and institutions place in his judgment. More recently, Dr. Brown has joined Retina Consultants of Texas, extending his care to patients in the Schertz, Westover Hill, and San Antonio Medical Center communities. He is also a distinguished member of the Macular Degeneration Association's Medical Advisory Board, and in fact, his relationship with the association runs even deeper. Dr. Brown is currently conducting a clinical trial on geographic atrophy, funded by the Macular Degeneration Association, groundbreaking work that holds real promise for patients living with this serious and progressive condition. Dr. Brown, you have our attention.
Thank you very much for that very kind introduction. I appreciate that. So, what we're going to be talking about today is a very interesting topic and a hot topic in ophthalmology, because for so many years there was not much we could do for patients who have geographic atrophy. We're going to talk about what it is. We're going to talk about how it relates to wet AMD, how it relates to dry AMD, and what are the treatments available and what's coming for the future. So I hope that you'll be able to take something home from this, that you will feel you had some value from what we're going to talk about. All right, so what is geographic atrophy? So first, just to get everybody oriented, let's talk about the eye itself. The retina is the lining on the inside of the eye. And if you look at the center of the retina, that part is called the macula. That's what does the area around our visual field, kind of in this zone around here. We get even more specific. Right in the very center of the macula is the fovea, and that's what we use for our central vision. That's to read, see details, recognize people's faces. That's the fovea that does that. Now, the retina has several different layers. There are the cells that actually respond to light. They're called the photoreceptors, and they're kind of sitting at the back wall of the eye. Underneath the retina are these pigmented cells. They have pigmentation to them, and they are cells that take care of the seeing cells. So they help transport nutrients into the receptor cells. They take out waste products. They absorb stray light, and they help in the processing of those photoreceptors and also in the quality of our vision. Then there's a barrier layer called Brooks membrane, this kind of yellowish white line that's going up and down on the screen. So we're going from front to back. And in the back, underneath all of this, is this rich network of blood vessels. And these blood vessels are supposed to let oxygen get through into the retina to help these photoreceptors work. Okay, so that's our anatomy lesson. Now, when you think about macular degeneration in general, most people have the dry type. About 6 out of every 7 people with macular degeneration, it's the dry type. About 1 in 7 are the wet type. We hear about the wet type so much more often because it can be very devastating and very quick. Someone can go from seeing very well and a year later not being able to read if it's not treated. And so that's why we hear so much about the wet, but the dry can also affect our vision. That's what we're going to talk about today. So what is dry macular degeneration? So the underlying condition of macular degeneration centers around these protein deposits that build up down here where those helper cells are. So these little deposits build up, and your doctor can look in your eye and see them and say, oh, it looks like you're developing signs of macular degeneration. We can actually see these little yellow deposits, and they're called drusen. Most of the time at this stage, the person is totally fine. They don't even realize that there's anything wrong with their vision, but these little deposits are slowly building up. And this is what it looks like when we look in. You can see these bright yellow dots scattered throughout this macula. So remember, we were talking about the macula, that area of the central field of vision, and then the fovea is right here. That's the very central vision right there. Okay. So in these areas where this material builds up, the retina over it can slowly deteriorate. And when we see that, it almost looks like a cookie cutter, like a punch out. You can see where this area is all pale. And that is where the retina is no longer functioning. This is basically dead retina. And that is geographic atrophy. They gave it the term geographic because sometimes it kind of looks like a map. It looks like a country or something. It can have all these different shapes. And that is what we're trying to slow down, because once you get to this point, anywhere there's the atrophy, you really can't see. So someone might be looking at a word, and if half the word falls in the atrophy and the other half of the word is in the healthy retina, they're going to only see half the word. They'll be able to see the first few letters, but they can't see the ending letters. Then they move their head or they move their eye a little bit, and then they can see the other letters because they're just basically moving this healthy retina into the zone where the word is sitting. So that someone could be looking at the table and not even see their coffee cup, but then they move their head a little and then it pops into their view. So it's literally like having a blind spot in your vision. And that is what we're trying to slow down with all the new treatments, is trying to slow down that atrophy. So like we were saying in the beginning, may have mild symptoms from these little drusen, but then it can progress to these large areas of vision loss. Now, the key thing, and many people ask this question, they'll say, well, I have wet AMD. Why am I getting geographic atrophy? You can see from that picture that the atrophy is just the underlying macular degeneration that everyone with AMD has. And then in that atrophy, some people can develop wet AMD. And they don't even have to have atrophy. They could just have the drusen. Let me show you some examples here. So just so we can both be on the same page of understanding the difference between wet and dry, we'll talk a little bit about wet because you can see how someone can have both. So when it's wet, this is when there's abnormal blood vessels growing into the retina. And we talked about how devastating that is. About 200,000 people in our country every year are diagnosed with new wet AMD. So we're going to go back to our anatomy slide. And remember those layers we were talking about. And here's what happens. So we see this material building up. These are the drusen, this yellow material. And you can see those are those helper cells we were talking about. And then these are the photoreceptors sitting on top of it. So these drusen start to build up. And what's happening is, remember the oxygen from these blood vessels down here? That oxygen is supposed to be getting up and percolating up to the retina and giving the oxygen to those actively working cells. But if this material builds up, it starts blocking the oxygen getting through. So the retina actually sends out a signal saying, we need more oxygen up here. So these blood vessels start to sprout. And they start sprouting up into the drusen or where this deposit is or next to it. And then as time goes on, they progress further, more blood vessels. Then you can see there's this blue fluid. That's the fluid leaking. They can bleed. They can progress further. And so that's what the wet form of it is. So you can see you could have these blood vessels growing up and have thinning of your retina. So that is why sometimes people will have both the wet and the dry at the same time. And if that wet isn't treated, you can get a big hemorrhage across your entire macula. You can get scar tissue that's left behind when the blood absorbs. And that's what we try to stop with all the medicines we use for wet AMD. And we've been using those medicines for 20 years. But the challenge has been we haven't had anything for the people who have just dry, just the thinning of the retina or the geographic atrophy. So that's what we're going to talk about next. Now, so here's an example. Here's another example. Now, in an actual patient, you can see these areas where the retina has just thinned out, just missing. It can take on very different patterns. First, people will notice some distortion because the retina is normal and then it drops down where there's thinning, then it comes back up and it goes across. So there's going to be distortion at those edges. But what's important is not only do you get those blind spots, people will have difficulty with their night vision because all of that material laid in the retina, those drusen, they're slowing down how the retina processes all of its nutrients and gets rid of its waste. So everything just works a little slower. So you need more light to see the things you used to be able to see easily. You might also have difficulty with contrast. Those receptor cells that do red, blue, and green may not be working as well. So it's harder to distinguish between blues and greens and black and dark blue. So you have more trouble with contrast. Someone looking at a bus, they might be able to see the bus, but they can't see the title of where that bus is going because there's a blind spot right over it. Everything around it may be very healthy, and words may look distorted. Parts of words can be missing. In terms of the risk factors for macular degeneration, we know that heredity, probably 70% of your risk of whether you're going to get it or not, relates to your family history. Age is another important one. The older you are, the more likely you are to have macular degeneration. Caucasian patients have a higher rate of having macular degeneration. Smoking increases your risk. Having low antioxidant levels in your blood, and that we're going to talk about that, how with diet you can help lower your risk for this presenting. And then high blood pressure makes any of these things worse. So controlling your blood pressure is also important. Your doctor will probably have you use an Amsler grid, which is just a way of detecting whether this distortion is coming on or you're developing a blind spot. And certainly if your grid starts looking like any of these two pictures on the right, you want to let them know that you're noticing changes from this normal straight grid. Some of the different tests that the doctor may do, you see, there's one test called a fluorescein angiogram where we can actually see the blood flow in the eye, and you can see all these little white dots that are lighting up on this left picture. Those are the drusen. And basically a dye is being injected into a vein in the arm, and then pictures are taken, and you can see all the blood vessels light up bright from the dye. Well, the dye is also going into these drusen. It can also highlight an area where the retina is thin. You can see here this thinned out retina. That's geographic atrophy, just the beginning of it. Here's another example where the dye is flowing in, and you see these light areas lighting up. That's geographic atrophy. Now, but there's an easier way for GA. We don't have to do an angiogram. We can do something called fundus autofluorescence, meaning it fluoresces on its own. It gives off light. So here's a picture of the patient's retina looking at a color picture, and you can see the atrophy. But then when we shine a particular wavelength of light, the drusen in the retina will shine back at the camera, and any place the retina is missing will look dark. So it makes it very easy to see the edges of the geographic atrophy, and you can see it all the way through here. Here's another example. Some people will have just one large area of atrophy. Some people will have multiple. It can start out with one little spot, and then you get another one and another one, and they can finally grow together. So these are all just doing that autofluorescent camera, and it's showing that the areas that are dead, are no longer working, are showing up dark. Here's an image. I want to show you how progressive this condition can be. So this is a patient who had that type of an autofluorescence picture taken. You can see some of these little white spots that are lighting up. Those are little drusen, those little yellow dots that we saw in the color picture. But then she had this picture done every year over about 10 years. And I want to show you how it can start out with just a few little drusen like this. And then year 2, starting to get some atrophy. Then the atrophy is growing bigger, year 6, year 8, year 9, year 10. And I want to show that again because it is so dramatic. Year 2, and these areas just grow and grow and grow. And up until the year 2003, all we could do is just look at it and tell people, yes, this is happening, but there's really nothing we can do about it. Another test that you can use is an OCT. You hear about this test being used looking for fluid in the retina. So when someone's converting to the wet form, we'll actually see fluid in their retina. Here is the retina up here. This bright red line, those are those helper cells we were talking about. And the blood vessels are down here. You can see some of them right here, these circular blood vessels. So this is a normal, healthy retina. Now let's look at one that has geographic atrophy. So this picture here is showing me what this person's image looks like when we just look in the eye, and you can see the pale areas. That's the atrophy. If we do a scan right across this area, you can see that bright red line that used to be nice and straight is now kind of broken up, it's jagged, and there's light shining through here. So all of this green going down is the light getting through because this line is not blocking the light the way it used to. It's broken up. So more light is shining deeper. So we can look at these images and say, yes, this person has geographic atrophy. So that's another way your doctor may diagnose geographic atrophy is using these OCT scans. Here's an example. You can do it in color. You can do it in black and white. And here's a black and white picture. Here's a retina. All this layer is retina on top, and this is the helper cell layer. And you see how the light is shining through here? It really shouldn't be shining through like this. It should look more like it is over here and over here. This light shining through is because the retina is missing in these areas. So this is where that scan was taken, right across here. And so that's another way your doctor may diagnose this. So some things we can do. We do know that having more green leafy vegetables in your diet, spinach, kale, collard greens, turnip greens, the leafy greens help slow down macular degeneration. Even in families where we know the macular degeneration runs in the family, the people who had more leafy greens, having fish once or twice a week, their macular degeneration progressed more slowly. UV light protection, so wearing sunglasses outside or glasses that block the UV, definitely help to slow down macular degeneration. Now, in people who have the intermediate level of AMD with large drusen and medium drusen, there was a very large study done called the Age-Related Eye Disease Study, or AREDS, and it was looking over 10 years at 4,000 patients, and it studied their risk of progressing their macular degeneration. And what they found is that if you took this formula of vitamin C, E, beta carotene, and zinc, your macular degeneration progressed more slowly. It was about 25% slower. So those where you see at the store with the AREDS vitamins, that's why we recommend that. Lutein is also an antioxidant, and it works to help filter out blue light. So the AREDS 2 formula, they added lutein to the formula, and they took out the vitamin A. Vitamin A is not good for people who were past smokers. And so, in fact, excess vitamin A might increase your risk for lung cancer. So they took the vitamin A out and they put in same antioxidants C and E and zinc, but they added lutein and zeaxanthin, which are two proteins that are part of the retina that help filter out stray light, and they take away the abnormal molecules that develop when UV light is hitting your retina. So they basically help protect the retina from damage. They're antioxidant. They actually had an arm of the study that people who got omega-3 pills, like fish oil tablets. And the interesting thing was, once again, the AREDS2 formula decreased the progression by about 25%. It's over 10 years. So it's never too late to start the AREDS vitamins. But the only thing that was a negative is that omega-3 fish oil tablets alone didn't slow it down. So there's probably something that's in fish that may not be just omega-3, or it may just be that if you eat more fish, you don't need as many hamburgers, one or the other. But whatever it is, having fish once or twice a week does help, but just fish oil tablets alone doesn't make a difference. So it may help other things. It can help your cholesterol level. It may help with your lipid levels. So it's not a bad thing to take omega-3 or fish oil tablets, but it doesn't slow down macular degeneration. So the take-home points of what we can do right now, these are the things, the green leafy vegetables, AREDS vitamins, realizing that there are multiple genes. So the genetics is a big part of it. Everybody's genetics is a little bit different. So that's why some people get wet, some people get just dry, some people get both. And those were all important findings in the discovery of this pathway of AMD. So now we're going to switch gears a little bit and talk about, let's focus on what is new with dry AMD. So the big finding with dry AMD is that there's this family of proteins, and I don't put this up for you to memorize any of this. This is just to show you how complex this is. This family of proteins that we all have in our bloodstream, and they help us fight infection, actually. But if you have little changes or mutations or changes in these genes where they don't work exactly right, this little process that works to actually kill bacteria starts getting activated at a low level. It's just running all the time in the background, and it's causing inflammation. And in the retina, it's the cause, or a big factor in the cause of the development of these drusen. So these proteins are it's stimulating inflammation, and you're getting this debris building up. So once they discovered this, they said, okay, so what if we block a couple proteins in this pathway? So you see this one in the middle called C3, and there's another one called C5. Two companies said, okay, we're going to try to block these from going on to causing the damage, and let's see what happens. So here's another example of GA. And what we're basically doing is we're recognizing the fact we can't give back tissue that's already lost, unfortunately. But if we could slow down how quickly this grows, at least people will keep the vision they have for longer. So it doesn't get to be a huge spot like this. That's the goal. So one of these is called, was developed by the company Apellis, and you'll see it at the store by the name Syfovre. The actual chemical name is pegcetacoplan, but it blocks that C3. And they did studies. So in this case, this is a graph showing how quickly these spots are growing. Okay, so if it's going up steeply, that's a bad thing. That means the spots are growing faster. And they showed after 2 years, patients treated every other month or monthly with this medicine, it grew slower by about 20% in the monthly group, 16% in the every other month. In 2 different studies showing that they could slow the rate of that progressing by getting these injections either every month or every other month. If you look out into the 3rd year, so people who've now been getting treated for 3 years, the amazing thing is it improves. It's more effective as you're on it for longer. So by the 3rd year, it was 35% slower in the monthly group and 24% slower in the every other month. And they've actually calculated, like by the end of 3 years, the amount of retina that you have saved is about a year and a half worth of retina that would have been gone. So you've saved about a year and a half of your macular degeneration. It's sort of like winding the clock back, or the clock is running slower. I guess that's a better way to say it. You're running the clock slower so those cells live longer. So that's important. That's important. And that's the medication called Syfovre. It came out in 2023. I mentioned there was another company, Iveric Bio, that was studying one that blocked C5, and they got similar results. You can see 28% slower after 1 year, and in this study, after 18 months, 30% slower. And that's the medication called Izervay. Same concept. It's an injection given every month or every other month, and it helps to slow down the growth of those spots. This is given as injection, just like we do our patients with wet AMD. Of course, we numb the eye. So many people are very nervous before they get their first one, and they don't even sleep at night the night before. But after they have their first one and they realize it really doesn't hurt, there are a number of ways we use to make the eye numb. And we use topical anesthetics. We use Q-tips with anesthetics on them to get the spot numb. Some people want a little extra. We can even partially inject a little anesthetic just on the surface of the eye for people who are very sensitive. And after the treatment is done, we rinse the eye, rinse out the antiseptic, have them use artificial tears afterwards. Now, the thing that Dustin was talking about earlier is the interesting thing. In the real world, we are finding that not only is it slowing it down, but actually some people are saying that they're seeing better, which is not what we were expecting. And in the beginning, I was thinking, oh, I guess this is just a very positive person. Like they think they're seeing better, even though we know this medicine doesn't do that. But we actually started, more and more people started saying that they were seeing better. So we actually did a big study looking at about 8 different retina practices and several thousand injections. And we saw that about 20% of the people are actually seeing better on the vision chart by at least one line. And that does eventually tail off. Like, it's not like a miracle drug. It doesn't just keep on seeing better and better. But it's nice to say, okay, I'd rather start at my baseline up here and then have it peter off than have my baseline start down here and have it peter off. But so it does decline over time. But the fact that some people are seeing better was something that we were surprised to find. And so we're going to be doing further studies looking at their OCT scans to see if there were ways that we can say who's the more likely person to get a gain in vision. We're also looking at some patients have had samples taken before their injection. We take a little sample of fluid and study that and see if there are proteins that are different in the people who see better than the ones who don't see better. So we're going to try to understand this better about that. What's the future? So there's a number of new medicines being developed. Like now we know that that pathway is the pathway and that you can slow it down. Many different companies are looking at different ways with other medicines through eye injections, sometimes through a skin injection. There's a pill study that's going on right now to see if we can slow it down without getting injections in the eye, and even gene therapy. If we could maybe put the gene into the eye that tells the eye how to make this medicine, it might be a one-time injection and you don't have to have injections every other month or every month. And so all of these are in process. These are no longer like pie in the sky one day. All of the things I just told you about are studies that are going on right now. So it's really an exciting time. Stem cells, the strategy with stem cells is trying to repair the area that's damaged. So everything I've talked about so far is just trying to slow it down. But maybe with stem cells, we could repopulate those areas where all those cells have died and help to bring back vision. Studies were done just kind of injecting these stem cells under the retina. And unfortunately, they didn't grow like normal cells do. They would grow in a ball, they would clump together, they didn't lay down flat the way they're supposed to. And so it really didn't improve anyone's vision. There's a company called Regenerative Patch Technologies, and they're developing a little implant. You can see this kind of looks like a broom-shaped implant that's just RPE cells that are all layered out on a single layer, the way they're supposed to be in the eye. And a surgery is done, and this is inserted under the retina to cover this area which is missing to try to repopulate the cells there and see if that will help improve vision. They've had some positive results, small numbers of patients at this time. So it's not really, it's definitely not proven, but the study for this is also ongoing. So that's exciting. And then we talked about, I mentioned gene therapy, about putting a gene into the eye that would actually give the eye the instructions of how to make the medicine. And that is being done right now. So I always like to mention to everyone who's going through this, because it can be very, very depressing to realize that you're losing your vision. And don't feel bad about expressing it. Talk to your primary doctor. Treat if you're going into depression. There are groups of patients who get together. See if there is a low vision group in your community. People will get together and talk about how they deal with things. How do they deal with the airport where they can't read the signs, and what do they do? How do they deal with going grocery shopping? Like, just getting together and talking about, they'll have a topic. They usually will have a guest speaker come in and talk about a topic, and then everyone will get a chance to kind of express what they're going through. And it's just better than staying at home and feeling depressed about it. Get out in the world. There's things called a low vision clinic where they will spend time with you more than just an ordinary typical eye doctor. They will spend the time with you to try to find things that will help you do the things that you like to do. You can register for disability that may get you certain benefits. If you're legally blind, you can get a tax deduction on your annual income tax. So just know that there are those things that are out there. So we are really living in a new age. Now we have a treatment for dry AMD, and especially patients with geographic atrophy. We have these amazing cameras that can help us better understand the disease. We're using genetics to understand these pathways so that we can design medicines to block the abnormal pathway. Remember that it's not just one condition. AMD is really many different conditions in the sense that everybody's genetics is a little different. Some people are going to get wet AMD and they're going to need one injection every 2 or 3 months, or one every 4 months, and they're going to be just doing great. Other patients need an injection every 5 or 6 weeks just to stay stable. And some people get GA, and not everybody gets GA. So it really is a heterogeneous group of patients, and that's why we're trying to design the treatments that will work the best for everybody. Stem cells probably will be helpful in the future. Growth factors that stimulate the healthy cells to keep living may be another strategy. So I want to say thank you for spending this time with me today, and I'm happy to answer questions with you. So, Dustin, do you see any questions that are in the chat?
I do. So,
Okay.
so you want me to read it to you?
Yeah, you can go ahead. Yes.
Okay, the first one is, how is geographic atrophy different from dry macular degeneration?
Yes. So they're very, very closely related. So the minute we see someone developing drusen, and it's not just one or two, but we see like little clusters of drusen in their retina. Once we see that, we call that dry macular degeneration. So the drusen are where you cross over to say, okay, this person has dry AMD. Then when the dry progresses and these little areas start to thin, so we start getting those blind spots, then that is called geographic atrophy. So geographic atrophy comes from dry AMD.
You ready for the next one?
Yep.
Can you lose all of your vision from geographic atrophy?
Yeah. So the good news is it is almost never the case that you lose all your vision. You can get these blind spots, and they can get very big, and to the point where you can't recognize someone's face, you can't read a clock on the wall, you can't see the words on TV, but your peripheral vision usually remains. So you can tell there's a chair across the room. You can tell there's a doorway. You can see the sun coming up in the morning, but you can't see the details. So you can be, quote, legally blind, where you really can't read the words on an eye chart, but you're not totally in the dark blind where you can't see where you are in a room. You do have your peripheral vision.
Very good. How should I monitor my vision for changes?
Yes. So that Amsler grid is one thing that we, pretty much give to all of our patients. So just put it on the refrigerator, look at it with one eye, make sure all the lines are straight, look at it with the other eye. And if you see changes on that, let your doctor know. You can also ask your doctor about this new technology, which is called a home OCT. There is this new technology where you can contract with a company. They give you a small home OCT device, and you can get an OCT scan once a week or every day if you want to do it every day. And that gets sent to your doctor, and they get an alert if it's starting to develop signs of wet AMD. And many insurances do cover for it, so we cover the cost of it. So that's another way of monitoring from home.
Are there new treatments coming out for this condition?
Yes. So right now, as we said, we had those two medicines for dry, the geographic atrophy. There are several medicines for wet AMD, and there are studies going on right now to try to make them all work better or last longer. So, yes, all those things that we talked about are actually realistic things. Like we may have a gene therapy for wet AMD, and then second, the next one that's going to come for dry AMD that will dramatically reduce the number of injections that people need. And even if someone didn't want to do gene therapy, some of these medicines are being developed as like a little pellet that slowly dissolves. And so that maybe instead of getting injections every 6 or 8 weeks, it might be once every 4 or 6 months. And those are very realistic. These are things that are in their final trials right now. So we're going to be hearing about a lot of new medicines in the next 1 to 2 years.
Very exciting. Is the eye exam different for geographic atrophy?
No, the eye exam is the same. It's the same checking the vision, checking the person's pressure. And then when we're looking at it, we're doing the same OCT scan that we would be doing to watch for wet AMD. And we can see these areas of thinning. That fundus picture where I was showing the autofluorescence, where you can see that black and white. And that is something that we do more so now because we're looking for geographic atrophy, because now we can treat geographic atrophy. In the past, there was no treatment. So there wasn't a lot of emphasis on looking for it. Now we're really trying to identify people who have geographic atrophy, catch it earlier, and those autofluorescent images are very helpful. So that's maybe the only thing that's really different in what we do in the clinic now. But now we sort of do that for everybody, where we get those autofluorescent images.
I have heard there is new supplements, ARIDS 3. Will that slow down the progression of geographic atrophy?
Yeah, so the AREDS 3 has basically everything that AREDS 2 has, and it has a little bit of other things added, like B vitamins and some other things that haven't been as extensively studied for macular degeneration, but they are healthy and there's nothing wrong with them. And um, so those things are fine to take. So AREDS 3 is fine to take, but the one that has gone through the most extensive study is the AREDS 2 formula. It's just AREDS 3 adds a few extra things to it.
I was diagnosed with geographic atrophy early stages. Are there any medications other than the shots that might slow it down?
As of right now, we really don't. The things we talked about, the uh, eating the healthy greens, UV light protection, the AREDS vitamins, and even the AREDS in terms of the dry, it's a little bit controversial. There are some studies that say that it slows down the dry, some studies that say that it doesn't. But we know overall, if you lump everybody together, there is a signal that shows that it slows the progression to advanced AMD. So I recommend to everybody to go ahead and take the AREDS vitamins. It may be that it's working really, really well for some people, and for some people it's sort of, so-so, and that's part of the genetic diversity. So, but if you lump everybody together, I think it is worth it, and they're so safe to take. I would say that everyone should just take the AREDS 2 vitamins if you can, if your stomach tolerates it. If not, find what it is in them that is bothering your stomach. Maybe just take vitamin C and vitamin E on their own, or maybe take lutein. You can get lutein on its own if you can't tolerate that big vitamin tablet every day. Maybe just take one or two of the things that are in the big vitamin and see if you can tolerate that.
Can photobiomodulation help with geographic atrophy?
Yeah, so photobiomodulation is another exciting thing. So last year, toward the end of the year, the FDA cleared a device that shines a wavelength of light that has a lot of red to it. So you may hear this thing about red light therapy. The red light stimulates the part of cells that does energy production for the cells. So it's thought by improving the energy production of these helper cells that are in the retina that they work better and they are able to get rid of this abnormal material better by being stimulated in this way. So they did a study with about 100 patients and they showed, and this is in people who didn't have GA, they just had drusen, and they showed that on average, people gained about a line of vision. They also saw that it seemed like fewer people went on to GA. Okay. They then, study ended, those people stopped doing the therapy. Later, they went back to those same patients and said, we're going to run this study again. And they found that their vision had declined. When they restarted them on the red light therapy, their vision seemed to come back up again. So this was not a huge study. It was only 100 patients. We're used to seeing hundreds of patients in our studies that get drugs approved. So it's very, very interesting. I'm glad that there's something for people who have just drusen alone and don't even have geographic atrophy. In theory, if it helps in areas where there's drusen, you would think that it would help for geographic atrophy also, but that wasn't actually studied. They didn't get 100 people who have geographic atrophy. They just had 100 people who had just had drusen. So in theory, it should, but we don't know that for sure. And I think we're going to learn a lot more now that the device is available and patients are getting it, and it's so safe. There were no adverse events identified from doing the red light therapy or the other term photobiomodulation, so no negatives to it. So for patients who are interested, I would say go ahead. And it's kind of an intense program. You have to come in several times a week for a few weeks in a row. Then you get a break, and then several times a week for a few weeks in a row. Then you get a break. It's a short treatment. It just lasts a few minutes. But yes, I think there is something there. It seems to be a signal that something positive is helping, and we just don't know fully all about it yet. It's very new.
And I believe that's what Sally was asking too. She says, what about red light treatments?
Yes,
So what
same
about
thing.
just the over-the-counter red light treatments? Anything just to broaden her question?
Sure, sure. So the hard part about it is all of these different devices, they may be a slightly different wavelength, like a slightly different shade of red. They may be a slightly different intensity of the red. So there's all these factors. And so it's hard. It's hard to put them side by side and say, oh, that one's going to work just as good as the study. So what we have to go with is what the ones where they actually had people in the study, and they actually had people who were getting the red light therapy, and then they had people getting a different wavelength of light. So it was like everybody was going through the process of sitting in front of the machine, getting something treated. So you actually had a control group, and they showed the people getting this particular wavelength of red light for that number of minutes, they did better than the people who didn't get it. So all the other devices out there, it's possible that they could be working also. They may not be the same strength or the same color of red, and so we don't know as much. So really, every device really has to go through a study to say, yes, this works just as well as the other one did. So we don't know about the other devices.
All right. And last one. At what point does one become legally blind with wet, dry, and GA?
Yes. So legal blindness for those conditions, for the macular degeneration, they define that as when you hit 20 over 200. So 2200 is like almost the biggest E at the top of the chart. The big E at the top of the chart is usually 2400, and then the line underneath that is 2200. So if you can only see that size letter, you are, quote, legally blind. There's another definition of legal blindness, which is how wide is your field of vision? That would be something more like patients with glaucoma or retinitis pigmentosa. They might be legally blind because their field of vision is shrunken. But AMD patients tend to have a good field of vision. It's just they've lost their central. So 2200 is the definition for legal blindness for AMD patients.
Thank you so much, Dr. Brown. Last call for anyone that would like to get a question in. We'll just give this one more minute just in case anyone has some lingering thoughts.
Well, I really enjoyed talking with you today. Thank you for taking part. And Dustin, do you have any closing words?
We just want to say thank you so much again for coming, Dr. Brown. We always appreciate your talks. They're always very informative and packed full of a lot of information that we can digest throughout the day. We
Right.
also want to thank our sponsors once again for helping us to put these programs on. And we also want to encourage everyone to visit our website at www.macularhope.org to find out when the next virtual program is going to be, as well as the subject. And then we are also doing, once again, we are also doing in-person programs, which I believe Dr. Brown is scheduled to do at least one of them. So you will see him somewhere in the United States to do a program. Thank you so much. You guys have a
You're
great
very
day, and we'll see you on
welcome.
the next one.
Have a good day.